Good morning, good afternoon, good evening, everyone. Thank you so much for joining us. Karibuni, as we say in Kenya, in Swahili, welcome. I'm Zain Verji. We're so excited to host this very first webinar of the Exemplars in Global Health program, and I am so thrilled to be with you. We've invited global health leaders to share how some countries are succeeding fighting COVID-19. We want to learn from their successes. I really hope that you draw inspiration from what they'll share with us, and that you will leave today's forum with a renewed sense of commitment to helping the world's poorest, the world's most vulnerable communities live healthier, more dignified lives. I'd like to take a moment as well to acknowledge our partners, the Center for Strategic and International Studies, the Center for Global Development, and Amref Health Africa for their support of this event. Asante Sana, thank you so much. It's now my pleasure to start this conversation with the co-chair of the Bill and Melinda Gates Foundation, Bill Gates. Mr. Gates, it's so great to see you. Thank you so much for being with us. Let me start by asking you to tell us more about Exemplars in Global Health, and where did this come from?
Well, as Melinda and I started learning about global health and the different outcomes in different countries, we were always interested in the huge differences. That is, countries that were at very similar income levels could have dramatic differences, for example, in under 5 mortality. And so, we thought we need to make sure that data is very good, and that's the whole global burden of disease, IHME work that the global health community has really come around. And so that data is far better, constantly improving. But just having the data, then it jumps out at you. Why are there these differences? An issue like stunting, some countries have reduced it. Peru's an example, more rapidly. What are the factors that go into that? In health, we don't have a marketplace where you see a price and somebody, outcompetes someone else. The word about best practices might not spread unless we really do the analysis and create a clear explanation of what was done well.
What do you think we can learn from Exemplars?
Well, if you just say that the countries that are lagging can adopt some of the practices of the leading countries, just in under 5 mortality alone, you could save literally hundreds of thousands of lives every year. I mean, in a way, you'd almost expect health to have the ultimate mechanism for spreading best practices because it's life and death. And yet, this ability to look in and really say, what worked and what didn't, it hasn't been as strong. And so there's huge upside. There are so many great experiments that are taking place. Of course, you have to see, is it a fit for your country? Not everything will translate because of cultural differences, but at least to be able to understand, what is it, and it's generally between countries, but also we take, for example, districts in India like Kerala and, see the phenomenal results they have and think, okay, can knowing about that help other parts of the country?
Bill, a couple of big picture questions for you before we get into the exemplars specifically. What does the impact of the pandemic tell you about our world today?
Well, it's a bit scary that the pandemic is harder to deal with in developing countries than in developed countries. And even though it starts out, the big caseloads in Europe and the United States, as it's getting into developing countries, the fact that it shuts down the primary healthcare system, that people aren't going in for their vaccinations, the bed nets and malaria medicines aren't getting out. We could actually see, like we did with Ebola in West Africa, we could see that this interruption in the healthcare system, with primary healthcare being the centerpiece of that, that could actually be responsible for more deaths than the disease is directly itself, particularly given that we have quite young populations, and we don't know yet what the case fatality rate in developing countries will be. We do know that just in malaria alone, if we don't get things back up and running quite well, that will have a rebound in deaths where we've been going down of an extra 100,000 deaths. So a lot of concern that as the health community comes together, that we're still maintaining the progress of the last decade.
What, in your view, are the keys to overcoming some of these massive obstacles that we're seeing to public health? There's the economics, there's the societal frictions that we're seeing, political tensions, issues of global leadership. How do you see it? Not a small question here, but what jumps out at you for us to take away?
Well, the foundation's one of our big focuses is not only making sure that the new tools, better diagnostics, therapeutics, and of course the vaccines, not only making sure those get developed very quickly, but that they're made available to the developing countries. And as yet, this idea of, okay, what should the priority be and how do we get money out to make sure the manufacturing capacity is better? So I'm very hopeful that it won't just be the rich world that gets these new tools. It will be all countries. And so, already thinking through, okay, when we get a vaccine, how would that be delivered? Or, if oxygen is such a key thing, or measuring pulse ox is such a key thing, can we get low-cost versions of that actually work in all the different settings? So, I'm seeing a lot of interest in that. The U.S. hasn't been engaged on this problem, not only domestically, but also in the global piece. But, hopefully that will change both in terms of resources and helping to coordinate the different activities. We need to get past this. We need to minimize the damage and then go back to the great improvements that we were able to achieve, where we were learning more and more about stunting and how we get vaccine coverage rates up. So it's great to see the community coming together to discuss these things, because we're having to act more rapidly than ever before.
You have a track record in investing in solutions and startups that advance global health. You're in the front seat seeing how startups and big enterprises are innovating to tackle the pandemic. So what insights could you share with us today from your vantage point about how the private sector is part of the global response and how the private sector is fundamentally changing because of COVID-19?
Well, if this pandemic had come, 5 to 10 years later, a lot of platforms, diagnostic platforms, vaccine platforms, monoclonal antibodies, antivirals, hopefully those platforms would have been more developed. I think now, with this tragedy, it will really force us to not only have these tools available, but also practice how we would use them and be more ready. It's very impressive that the countries that faced SARS and MERS problems are, when you look at the exemplars that'll be talked about, there's really a strong correlation between the kind of practice and planning they did to deal with those epidemics, which fortunately weren't that gigantic. It made them realize things that, should be obvious, like, okay, we have testing capacity in the commercial sector as well as in the public hospitals. How do we stitch that together, get that capacity up, get the data integrated, on a daily basis, actually see where there are problems? And so not only will our tools base be improved with some of these platforms, but I do think the world will see the importance of primary health care, and that we'll actually practice the steps to take, because when you have exponential spread, just doing things a few weeks earlier, can make such a dramatic difference. And, so now we have countries that are near zero, and certainly they're the envy of the other countries. And, of course, when you get low numbers, then things like contact tracing become very doable. Whereas, in many parts of the US now, even if we had, great staffing and everybody was participating, it would be very hard to do contact tracing when the volume of cases is very, very large. So, I think the global health community can look back and say we were warning people about this, but maybe we didn't get them to pay attention as much as we should have. Now, we have their attention. The private sector innovations are very, very promising, but they have to be, allocated. And it's not clear who's pulling all of this together, because we didn't do a dry run to say, okay, the monoclonal antibodies. Well, what if one company has the best ones, but the other companies have that manufacturing capacity? Likewise with the vaccine. So it's a bit ad hoc. I talked to the CEOs of the pharma companies and their interest in helping, showing their capabilities, coming out of this with a much more positive understanding of the work they do than before this. I think that attitude is there. And the next 6 months, there are going to be a lot of new tools, hopefully priced low enough and easy enough to deliver that every country can benefit from those.
Bill Gates, thank you so much, and thank you for all that you do. Let's take a look now into the positive outliers themselves and the COVID-19 exemplar country selection. I'd like to welcome Professor Peter Piot, Director of the London School of Hygiene and Tropical Medicine, to talk to us a little bit about the methodology behind the COVID-19 exemplar country selection process. Peter, great to see you. You're looking well. Thank you for being with us. So walk us through what exactly are the positive outliers and why should we study them?
Yeah, hello, Zane, and hello, everybody. There are many words that can characterize this pandemic, but uncertainty is certainly one. And also the huge disparities among countries in how they've been doing with, this in front of this epidemic. And a second point is that's really important when we think of exemplars is that we're only at the beginning of this pandemic. That's a sobering thought. But that's why learning is so important. And we're all learning while we're sailing, or I should say learning while we're racing, and how to do better. And that's why exemplars come in, and along the lines that Bill just described, even if indeed every country's situation is quite unique. Together with the rapid support team, public health support team of the London School of Hygiene and Tropical Medicine, and our World in Data, we developed an analytic framework so that our assessment of country performance in the face of COVID-19 goes well beyond media headlines, because that's something that is driving it. We looked at countries with a population of at least 5 million people, looked at the situation 21 days since the 100th first case, high quality data on testing, all that was in there, and then a number of indicators to capture the situation. That goes from the number of tests per confirmed case, deaths per capita, extremely important, things that we can more easily analyze. And from that analysis, the relative success of countries like South Korea, in Europe, Germany, Vietnam against COVID-19 offer lessons to the rest of the world. And in Germany, I would say in Europe, Germany is undoubtedly the outlier, the positive outlier, because I should say we should also study the failures, because there are quite a few and probably even more, and learn from that what not to do. But in Germany, we have a fantastic synergy between strong national leadership, starting with Chancellor Merkel, but also local implementation, local leadership, and combined with very early expansion of testing and resources that were really given at a local level. South Korea, another example, quite well publicized, that one, again, with strong combination of, testing and leadership and resulting in very late. And then there's Vietnam, perhaps less well publicized in the West, certainly not, but they have had no deaths. And, and looking at tests per case as was one of our indicators, Vietnam is a real outlier because, in fact, in May, they stopped reporting because there were no cases. So that's the best situation to be in. And so we will hear now from, the person who is leading that effort in the country.
Let's look at that best situation. Peter, we'll drill down on some of the stuff that you were saying just now shortly, but let's look at Vietnam as a COVID-19 exemplar. Of a population of nearly 100 million, there are only a few hundred recorded cases, and as Peter was saying, no deaths. That's amazing. I asked His Excellency Vu Duc Dam, the Deputy Prime Minister of the Socialist Republic of Vietnam, about their key success factors and some of the lessons that they learned. So here's a little bit of what he said.
Xin chào buổi sáng các bạn từ Việt Nam. Tôi xin cảm ơn các bạn đã mời tôi tham dự cái hội thảo này. Trước hết tôi xin bày tỏ cái lòng biết ơn đối với tất cả cái đội ngũ y bác sĩ trên toàn thế giới đã và đang nỗ lực chống dịch. Tôi cũng xin đánh giá rất cao sự nỗ lực của tất cả các tổ chức quốc tế, các chính phủ, các tổ chức và cá nhân để cùng chung tay chống lại đại dịch. Có nhiều bạn bè cũng như là nhiều quý vị hỏi là tại sao Việt Nam có thể làm được như vậy? Thì tôi sẽ xin kể chính xác những gì chúng tôi đã làm thôi. Thứ nhất là chúng tôi rất chủ động. Ngay từ giữa tháng Giêng thì chúng tôi đã lên một kế hoạch để chống dịch với các kịch bản khác nhau, từ vài chục người, vài trăm người, vài nghìn người, thậm chí đến vài chục nghìn người bị nhiễm. Và chúng tôi tổ chức diễn tập cho từng cái kịch bản đấy. Thì tại sao lại chúng tôi phải làm như vậy? Bởi vì là chúng tôi ý thức được là hệ thống điều trị của Việt Nam thì còn hạn chế, không thể so được với các nước phát triển. Cho nên là chúng tôi buộc phải làm mọi cách để mà không có nhiều người bị lây nhiễm. Và tinh thần của chúng tôi là luôn luôn lường đến cái tình huống xấu hơn để tình huống nó không xấu đi. Và phương châm là tính mạng và sức khỏe của con người là phải được đặt ưu tiên hàng đầu và không ai bị bỏ lại phía sau. Thứ hai là chúng tôi tuân thủ chặt chẽ cái nguyên tắc chống bệnh truyền nhiễm. Đấy là phải ngăn chặn bệnh xâm nhập từ bên ngoài, là phải phát hiện ngay những ca bệnh và truy vết tất cả những người tiếp xúc. Đấy là phải thực hiện cách ly. Đấy là phải khoanh vùng từ khi quy mô còn rất nhỏ. Và về phía điều trị thì bất kể bệnh nhân nào bị nhiễm là chúng tôi đưa ngay vào bệnh viện để điều trị ngay từ đầu, để không bị bệnh nặng lên. Cái phương châm của chúng tôi là hãy hành động sớm hơn một bước. Hành động đúng và sớm thì sẽ tránh được tổn thất về tính mạng, về sức khỏe và tiết kiệm được chi phí chống dịch. Thứ ba là chúng tôi xác định không thể nào chống dịch được nếu toàn dân, toàn xã hội không tham gia. Và chúng tôi đã sử dụng tất cả các phương tiện thông tin để thông tin đầy đủ đến với mọi người về căn bệnh, về mối nguy hại, cũng như là về cơ chế lây bệnh. Để tất cả mọi người dân thì đều hiểu biết và làm theo những cái hướng dẫn của cơ quan y tế. Ví dụ như là hạn chế không đi ra ngoài, và khi cần thiết đi ra ngoài thì phải đeo khẩu trang, phải rửa tay thường xuyên, phải để nhà cửa nơi làm việc là thoáng gió, thông thoáng. Và người dân thì không chỉ là thực hiện các cái biện pháp để phòng bệnh, mà còn có rất nhiều cái sáng kiến để hỗ trợ nhau mà rất là cảm động. Ví dụ như là làm ATM gạo, và tất cả thì đều rất là minh bạch, rất là nhất quán, và người dân thì rất là tin tưởng, đồng tình và thực hiện theo các cái khuyến nghị của chính phủ và cơ quan y tế. Cái điểm thứ tư ấy, là chúng tôi rất là chú ý để sử dụng công nghệ thông tin trong cái chống dịch. Không chỉ là vấn đề truyền thông như nói ở trên, mà các cái công ty đã phát triển rất là nhiều các cái ứng dụng để giúp cho chống dịch. Đặc biệt là để truy vết những cái người nhiễm bệnh và những cái người có tiếp xúc với người nhiễm bệnh. Ở Việt Nam chúng tôi gọi là F0, rồi F1, rồi F2, rồi tới F3. Thế và phía điều trị cũng thế. Chúng tôi kết nối tất cả các bệnh viện. Chúng tôi tổ chức các cái buổi hội chẩn từ xa với sự tham gia của các chuyên gia hàng đầu để mà tìm ra các cái phác đồ điều trị tốt nhất cho các bệnh nhân nặng. Và có lẽ đấy cũng là một trong những cái yếu tố để Việt Nam đến ngày hôm nay là không có ca bệnh tử vong nào. Thì tôi muốn nói 2 điểm ở Việt Nam chúng tôi thì từ nhiều năm chúng tôi đã chú ý và tới đây chúng tôi sẽ chú ý hơn. Thứ nhất là về y tế thì phải chú ý hơn đến cái hệ thống y tế cơ sở. Ở Việt Nam thì chúng tôi có trên 11.000 cái trạm y tế cơ sở và chúng tôi có nhân viên y tế đến tận từng làng, từng xóm. Cái hệ thống y tế này hiện nay đã được nối mạng và tới đây thì chúng tôi sẽ tiếp tục tăng cường và củng cố. Và thứ hai là Việt Nam thì người dân Việt Nam là từ lâu có cái thói quen là dành dụm tiết kiệm và chia sẻ với những người xung quanh khi mà khó khăn. Cộng với đó là chính sách an sinh của xã hội là rất là quan tâm đến người nghèo. Cho nên như Việt Nam thì chúng tôi có thể, nếu cần thiết thì có thể thực hiện giãn cách xã hội một thời gian dài mà cũng không có những cái bất ổn. Tôi có lòng tin là nếu mà chúng ta tăng cường hợp tác hơn nữa, đặc biệt và trực tiếp nhất bây giờ là trong nghiên cứu sản xuất và kể cả phân phối vaccine để mọi người đều có vaccine, thì nhất định là chúng ta sẽ chiến thắng được đại dịch. Tôi cũng hy vọng là những chia sẻ của tôi thì cũng đem lại một số thông tin để tất cả các bạn cùng tham khảo. Tôi xin trân trọng cảm ơn.
Thank you so much, His Excellency Vu Duc Dam, with a first-hand experience of fighting the virus on a national scale. You can find the full video of his interview on our website at exemplars.health. All right, let's take a look now in a little more detail at the lessons learned from COVID-19 positive outliers. And I'd like to welcome Dr. Tom Frieden, the former CDC director and president and CEO of Resolve to Save Lives, and Dr. Soumya Swaminathan, the chief scientist at the World Health Organization. Tom, talk to us a little bit about Germany and South Korea. Build on what Peter said. What did we learn there?
I think it's really important to emphasize that there is no one perfect, one-size-fits-all response, but there are some characteristics that the most successful places share. They do better with leaders who are committed to facing facts, fears, and failures, and able to adjust. It comes down to being data-driven, to using information to continuously improve the response, and to fully supporting and being guided by public health. And as I look around these and other parts of the world, what I see are really a series of very important principles. One organized system, so that it's not every place within a country on its own. Even with the decentralization of Germany, they had one approach. Human contact tracing. There's been a lot of attention to digital products, but fundamentally, this is about disease detective work and building bonds and supporting people. Free testing with rapid results that are appropriately used. Support for patients and for communities. Fast action. Weeks, hours, even days can make a huge difference here. Just a 1-week delay is the difference between a few hundred or a few 100,000 cases in some countries. Innovation is so important, and we're seeing all sorts of innovations being done in real time to improve the response. Protection of the most vulnerable communities, whether it's the elderly in Germany or look in other places where more needs to be done to protect the most vulnerable. Clear communication, so there's one message. A data-driven response that is based on public health principles and a strong public health system at baseline. This is perhaps one of the key long-term lessons. We need to invest in the public health system so that it can address the problems of today as well as the emergencies of tomorrow.
You know, the countries like Germany, like South Korea, I mean, they have way more resources, right? So when you look at that, what are some of the additional things that they were able to do that other countries can't?
Well, actually, I think the resources that every country has are human resources. And we've seen all around the world countries doing things like figuring out how to make hand sanitizers and face shields or cloth face coverings. Every community has strengths and every community has vulnerabilities. And the key to success in fighting infectious diseases is to enlist those strengths in the combat of the disease and to address the vulnerabilities, whether those vulnerabilities are things like migrant workers in dormitories or in Singapore or in the US, are long-standing and unacceptable racial disparities in health status and health access.
Dr. Swaminathan, we've been seeing an unprecedented level of research, scientific collaboration worldwide. Could you tell us a little bit about what we've learned so far from these exemplar countries from your point of view at WHO?
Thank you. And I agree with what the previous speakers have said, what Peter and Tom just said. And I think the one thing that we've done is in this pandemic is to really learn from each other. We started with learning from China and what they did and the huge amount of research that Chinese scientists were able to do, even in the midst of this awful outbreak in Wuhan. They were the ones who provided us the first information about the epidemiology, the clinical profile management, and they were even able to do randomized clinical trials for some repurposed drugs. What I would say has been, I think, also unprecedented is the enormous amount of scientific collaboration that we've seen. The WHO brought together scientists and researchers from all over the world very early on in February. And since then, we've had these networks of experts that speak virtually every week or sometimes more than a couple of times a week and have been so open and generous with sharing information, sharing data. The journals have all got rid of their paywalls. We see huge amounts, of course, of preprints, which sometimes can be quite challenging. My team has been screening anything from 500 to 1,000 publications a day in order to update our guidance. And as you know, we have been trying to update our guidance as new evidence becomes available. It's been a little bit, doing science in the spotlight, which is, I think, quite unlike normal times when scientists do their work and then people become aware of it only when there's a big advance and, things happen incrementally. But here, every paper is scrutinized and examined and implications are discussed in the lay, media, and the public. So that's sometimes a little bit of a challenge. So we're working on treatment guidelines. We're working on updating our briefs. And where necessary, we've also brought countries together to undertake research. The Solidarity Trial for Therapeutics, for example, was set up as a multi-country adaptive platform where many therapeutic agents could be tested as and when they became available. And the benefits of having a distributed and diverse model is to have do the studies where the epidemic is raging.
You're the chief scientist at the World Health Organization, so there's no better person I can ask than yourself this next question. Are you concerned that science and expertise are getting the short shrift by some governments that are in pursuit of only political goals? Do you see sort of an anti-intellectual bias and anti-expertise bias? And how do you and other scientists deal with this?
Well, this is something that's very sad to see. And yes, it is true. But we've also seen, I think the Exemplars actually brings out for us the common features that countries that have done well have demonstrated. And I think Tom Frieden just laid them out very well, starting from strong leadership and political commitment, taking it very seriously right from the beginning, but also depending on national institutions, your own scientists and public health leaders, focusing on doing things based on your own data as granular as possible. And then I think trust between the community and the government has also played a very important role. And I think these are some of the common features that you see across rich and poor countries that have done well. And I think one of the things that has been quite remarkable is the fact that it doesn't automatically mean that high-income countries have done better than low-income. Not at all. In fact, we've seen many high-income countries really get into terrible trouble with this pandemic. And therefore, I think it's more how well prepared the public health response, and whether there is a public health cadre and an infrastructure that could rise to this challenge. Not just the tertiary hospitals, which of course are much better equipped, do much better in the high-income countries, but the basics of the contact tracing, the tracking, the lab capacity, the surveillance, and just being able to have that on the ground workforce, I think has not necessarily happened everywhere uniformly.
And how should we understand the Indian response?
I think the Indian response has been strong. They responded early. They took the early warnings very seriously. They set up national and state level emergency operation centers. The first few cases were detected, in fact, on the day that WHO announced the public health emergency of international concern on January 30th, were the first few cases in Kerala. The other remarkable thing, I think, has been the fact that at the time when this pandemic happened, many countries were dependent on importing diagnostics. And in fact, that was one of the big bottlenecks early on, where there was not enough diagnostics in many countries, except for those that, had their own capacity to manufacture. And very quickly, India was able to go to completely indigenous manufacturing of diagnostics. And today they're doing over 350,000 tests a day, starting from a few thousand tests a day in February. So I think that's been remarkable. The other thing, of course, is that India has had, it's diverse in terms of how each state is a little bit different than the other, but the states that have had a good public health cadre have actually shown that early detection and aggressive action actually is able to contain the infection to low levels. And I think Kerala was mentioned as an example by Bill, but there are other states as well, mostly in the southern part of the country that have done well.
Let's look at some of the more limited resource settings in certain countries, because countries that have had far less resources have done wonderfully in some aspects that we've been discussing. So let's just take a little bit of a closer look there with Dr. John Ngengasong, the Director of Africa CDC, Dr. Carissa Etienne, the Director of the Pan American Health Organization, and Dr. Mohamed Pate, the Global Director of Health, Nutrition and Population at the World Bank. Let me start with John. Let's look at Africa. What does Africa need to do as a continent right now to fight the pandemic? As we've been seeing cases have risen significantly over the past weeks with something like over 700,000 infections.
Thank you. I would like to see the pandemic in Africa in phases, where in the very first phase, we had what I would characterize as a delayed pandemic. And I think which was characterized by a strong ability to coordinate and a strong ability to lead from the highest level of the continent, especially the kind of leadership that President Ramaphosa, in his capacity as the chair of the African Union and Chairperson Moussa Faki of the African Union Commission exercise. I think I start with that because it played a huge role in blunting the very early takeoff of the pandemic. I was always clear that from the Africa CDC perspective, it was a delayed pandemic and not a missed pandemic, which is people were characterizing that maybe Africa has been spared with this. Now we are in a different phase of this pandemic, which I would characterize as the takeoff phase on the continent, with, as you rightly said, with over 700,000 cases now, with close to 16,000 deaths. We are now seeing about 100,000 new cases a week. So I think we have to adjust our strategy. And the good news still in Africa is that of the 55 member states, 37 of them still have less than 5,000 cases of the COVID-19. So that still offers a unique opportunity to do a couple of things that Tom has mentioned, Peter and others, which is expand our testing as quickly as possible, reinforce that with contact tracing, and make sure that we have the right facilities to take care of those who are infected. We launched actually at Africa CDC what we call the Partnership to accelerate COVID testing, which was underpinned by 4 things. One was to make sure, as Sonia mentioned, to increase our testing, which was very limited. Today, we are still not there, but at least we've made a very good, we are making progress. We are around more than 6 million tests being conducted, and the test is becoming more available. So we really count on that. But secondly, back to that is the community efforts to win this fight and increase our contact tracing. We need to deploy really large number of community workers to boost that ability to trace and isolate people. The window is still there for the continent to do these things that we put out there. And I think that is clearly some of the things we have to do, like social distancing, masking. I mean, we are calling for universal masking all through the continent, and I'm happy when I drive through the streets of Addis Ababa and see that nearly everybody, I literally count, and to find people who don't have masks on their face. And I'm really proud that a city like Addis Ababa is almost, has been masking all around. So those are things we have to do, of course, and but do that boldly, do that aggressively on the continent.
Carissa, let's look at Latin America. Some have fared better than others on the continent. What have been some of the key differentiating factors in Latin America?
I think early and strict implementation of preventive measures has been essential, as well as understanding the local level dynamics. The English-speaking Caribbean countries, for example, have been extremely successful in this regard, by quickly and aggressively implementing preventive measures, incorporating local dynamics, and utilizing the primary healthcare systems and the primary healthcare approach into their response. They were able to limit the virus's impact. This notion is particularly important as some localities begin to consider lifting certain restrictions. By understanding what makes each locality unique, we can tailor policies and responses to the necessary context.
Dr. Pate, how do you see the situation, particularly when it comes to trying to balance in places like Africa or Latin America, full lockdowns versus letting the pandemic take its course, which is different in every country's context on the continent? As a Nigerian former health minister, how do you see that challenge?
Well, thank you. I think from the foregoing discussion, it's very clear that exercise of leadership at the right place at the right time matters, and that is a single differentiating factor in terms of how countries have done well or not done so well. But beyond the individual leaders or collection of leaders is how they are organized and how they manage to build up their national responses. In the context of the low-income countries, what is very clear is that the strict lockdown that was obtainable, let's say, in the high-income countries was impracticable. If you go to Abuja or to Lagos or to Accra, where there's no power, no jobs, lots of informality, it's much more difficult. And that's why the bank's response, when we announced it, included social protection within a package of response effort that really tried to address this issue that is adapted to local context. And that is key to building the trust of communities and citizens to follow the behaviors that the public health experts are actually saying are necessary to numb the trajectory of the pandemic.
John, do you agree?
Absolutely agree. That is, the community response, community leadership and community ownership is key, and it has to be underpinned by trust. I think one thing we've learned over the years, of course, on the continent is that without that strong community relationship, you tend to fail. Very clearly. So I think we should always explain very carefully to build a trust with the community why we're asking them to mask, why we're emphasizing social distancing, and why we're calling for people to do the things that we are asking them to. But without that, I think we can't just decree those into the pop community.
John,
the battle we won and lost at the community level.
Can we do social distancing in Africa, given some of the high density areas and different challenges that we face on the continent, that we can't really derive some of the exemplar lessons from there? And same with Latin America.
No, absolutely. It has been a challenge all through this exercise. And again, as I drive through the streets of Addis Ababa, you look at the coffee shops that are still clustered, and but people are masking. I think that much. I mean, they're putting on their masks as much as possible there. So that is where we really have to look at the response from the community by building those relationships with the religious leaders, community leaders, so that they can inform us and guide us as to how to implement those measures within the communities.
Carissa, what did you see in Latin America that we can take away?
Well, certainly I believe that as the pandemic moved into the informal sectors and the urban poor, indigenous and Afro-descendant, I believe it was extremely important to ensure social protection. I believe as well that it was extremely important to use community-based leaders and community-based groups to work with the population. And it is very clear that you need to engage people in their own settings. And the whole question of how are these poor, disadvantaged people, how do they have access to the basics of life that allows them to be best able to protect themselves and to safeguard against the pandemic? And that has been a really very difficult lesson for the Americas.
We'll get to that. We'll get to that piece shortly. Let's focus a little bit now on the hotspots themselves and what we learn from them and what we can learn going ahead, because we've seen new hotspots emerging during the course of the pandemic. Others fade as local mitigation measures take effect. And so let's talk about the hotspots and to people that are dealing with or have dealt with those situations. Professor Piot, first of all, how are you feeling? You know, you were infected with COVID very early on. What was it like for you? And are you okay? Have you recovered 100%, or are you still struggling?
I'm getting closer and closer to 100%, but I'm much better, thank you. After 4 months of not only the acute infection, but what's clear to me is that there are going to be a lot of people with chronic conditions, with sequelae and so on. And that's one of the things I've learned a bit. And it's, it's not just a little bit of a flu or you end up in intensive care. There's a lot in between. But it's given me a totally different insight. And I feel now, after having fought viruses, I know a virus got me. And so I'm now understand better and I hope double motivated to defeat this one. Yeah. But we are, I'm also more and more mindful that in Europe, once the epicenter, still problems, but we've done, most countries have really been successful in bringing down new infections, but it's an extremely fragile and constantly evolving situation. And that worries me enormously. And that probably will be the, how the world will be for the next maybe few years, even when we have a vaccine. And it'll be like outbreaks here and there. And when you look, for example, going back to Exemplars, the countries that have done well, like Singapore, excellent job, but migrant dormitories, huge problem. South Korea, nightclubs, where one source. Germany, meat packing, or slaughterhouses. Melbourne, high density housing. Leicester, garment, work sweatshops. So it's gonna pop up here and there. And, yeah, you want to say something? I see. Yeah.
Oh, I always want to say something. Actually, I wanted to ask about the long tail of all of this in hotspots and beyond, right? So the impact, the societal impact, the mental health impact that we're going to have to grapple with, and the physical impact that yourself and others having to endure. How do you see that? Yeah.
I think, first of all, I think epidemics really expose the fault lines in society. I mean, we've seen that with HIV, we've seen that with every epidemic, those who are most vulnerable, discriminated and so on. So we see it in the UK, where people are, Black and ethnic minorities are far more affected. but also the examples I gave often are among populations of people who are, just at the most marginal and more vulnerable parts of situation of the society. And so, in addition, we have mental health impact, but both of the epidemic itself of COVID and being ill and so on, but also of the lockdowns and all that. I mean, look at gender-based violence has gone up in about all countries as a result of that. So we have to look at everything together, not just the virus. But also, I think that what we've seen is that the spread of the virus goes through super spreading events and hotspots. And it's probably more accurate to say super spreading locations. These are hotspots, the ones that, so it's less about individuals, but more about vulnerabilities, locations, and that's a very important lesson for the future, because we have to repair the roof when the sun shines, no? I mean, now we have a bit fewer infections in Europe at least. So this is also the priority now for the European Union. Get ready for these hotspots. And what we need is to map it out, have some kind of heat maps, because it's pretty predictable. Already during the height of the epidemic, who were the people who most affected? Care homes, the elderly, lots of also in transmission in hospitals. So these must become safe spaces. But we now must be ready for where the epidemic will move next. And that's a combination of epidemiology, social science, knowing what's going on, and have above all the data and real-time feedback to the local communities. Like what Mohammed and John have just said.
Tom Frieden, you're in a hotspot. I'm in a hotspot. The situation in the United States is pretty alarming. What, in your view, can we do today to salvage the situation we're currently in?
I think when you look at the US response, you see frankly, a real failure of leadership. No strategy, no plan, no organization, and just about the worst communication you can imagine, with becoming controversial and partisan over masks and testing and schools policies. It's fine to have scientific debates, but to make things political statements, this is one of the fault lines in our society. We in the US are living in a hyper-partisan time. And Peter said it perfectly. The virus exploits the fault lines of societies. All infectious diseases do. And in the US, that includes partisanship. That includes our healthcare system, which is not well organized. That includes our lack of good infection prevention and control in hospitals and nursing homes. Nursing homes, as I said 4 months ago, are ground zero of this disease, and about 40% of the deaths have been in nursing homes. Our shocking and unacceptable racial inequalities are a vulnerability for our society and are reflected with much higher death rates among African Americans, Hispanics, Native Americans, American Indians. So this is key, but you ask a key question: how can we do better? Well, we hope for better leadership. We hope for states to take the lead. But what we need to do is we need to be on the same page. We need to have core indicators we all track so that every person can know what their risk is, and so that every organization and individual can know how well their government is doing controlling COVID. In the US, we're developing such an enormous viral reservoir with millions of people infected. It's just almost inconceivable, the scale of the difference. You see Hong Kong taking extraordinary action with 100 cases, and the US approaching 100,000, and still they haven't shut bars and restaurants in most of the country. But it's not all of the US. All epidemiology is local, and you're seeing differences in meatpacking, nursing homes. You're seeing the northeast of the US that has so far largely controlled to some degree the pandemic, but is at enormous risk from migration internally from other areas. You're not going to be able to replace competent leadership. And what you saw in the Exemplars is a good national strategy that then is rolled out with local engagement with communities and local public health. In the US, we have both the weakening of public health systems at state and local governments and the lack of national leadership.
How would you rate the CDC's role thus far?
The CDC has been sidelined and undermined. There's no doubt there are things they need to do better and differently, and every organization should learn from this experience as to how they can do better. But what's most striking is that for the first time in the 74 years that the CDC has existed, we're not hearing from them regularly. So the US public is not able to walk the path of discovery with CDC as we learn, for example, why face masks are important, what can be done to drive down the epidemic, how contact tracing really needs to be done well. And that sidelining of public health has been really one of the hallmarks of ineffectual responses all around the world.
So if you were Dr. Fauci today, how would you be dealing with the White House?
Well, I think it's hard to beat Tony at what he's been doing so well for more than 3 decades, which is speaking truth to power, speaking truth to the public. One of the things I wish was that in addition to Tony's wonderful voice on research issues, we were hearing a public health voice from CDC on the public health issues that have to be addressed in this pandemic.
One more briefly, Tom. Are you in favor of opening schools and universities this fall?
I think it really is a matter of doing it carefully, understanding that it is crucially important. Bill Gates was talking about primary care and how if we don't protect primary care in lower income countries, there will be more deaths from malaria, measles, and other conditions than there would be from COVID. And in the same way, we have to balance in the US the need for educational support, for social support, for mental health support, through particularly the K through 8 schooling is extremely large. That's why we're urging everyone to understand that we have to control COVID in the community so our kids can get to school, so we can go back to work, so our economy can recover, so we can save tens of thousands of lives. But it's not going to be easy. Every school, every university is going to need to adapt to the new normal of COVID. This is not going away. Even as Peter said, with a vaccine, we're going to have to deal with COVID for time to come. So for that we need to use data. We need to move forward and learn from experiences, protect our kids, protect our teachers and staff, protect the universities, figure out how to adapt and to move forward with the enormous challenge we have of the number of cases, the decrease in spread, and the strengthening of public health.
Peter, what do you think of what Tom just said? How is Europe looking at the United States today?
Well, I have a 100% agreement with Tom, but we also are not perfect. Let's put it that way. One of the issues is that several countries were quite late in terms of reacting, and we know, as Tom said, 1 week can mean the difference of thousands of people who are alive or die. But now I think there is quite a good united effort. I mean, what's great is that Ursula von der Leyen, the chair of the European Commission, really has taken this on personally. And for example, that's reflected also in hosting pledging conferences for R&D, but also to have access to vaccines, but without falling into vaccine nationalism. So for that the vaccines produced in my country are only for my citizens. No, we need also ensuring equitable access to, to vaccines and therapeutics. The fact that remdesivir was completely bought basically by, by the US denies then the other people in the world from, from benefiting from it. But it's not going to be over. So we are all, have to prepare for the long term. And that's difficult because we're in the middle of an acute crisis. But we need to think of the long term, building the systems again. And I was thinking when I saw the Deputy Prime Minister of Vietnam, if Vietnam can do it, they're limited resources. Why can't every country in the world do what they've been doing? It's as simple as that. And that's an exemplar.
Carissa, do you see amid hotspots in Latin America, countries that are able to harness what Vietnam has done so successfully? I mean, is that possible given the local context and the resource challenges? I mean, obviously is Vietnam's case.
Well, I gave the example of the Caribbean countries who really have limited resources, but have done very well. Of course, Brazil and Mexico are our worst affected countries, but we know that Argentina, Chile, Colombia, Ecuador, Guatemala, and Peru are likely to suffer high tolls as well. But in particular, the borders, the population around the borders, the indigenous people. And yes, we have seen the countries instituting preventive measures that worked initially very well. We have seen them coming together to address strategies across countries that would best help them to lower the curve and so minimize the impact. But they are having difficulties. Some of it is leadership difficulties. We find where there is a strong public health sector and primary healthcare sector, then that makes it more efficient at ensuring that they meet the challenge. But it is challenging in a situation where healthcare systems have not been very well developed, and there is such inequity as far as access to healthcare.
Final word on hotspots, Tom, before I let you go.
Well, unfortunately, any part of the world could become a hotspot at any day. No one is immune from this. And that's why it's crucially important that we strengthen our core public health systems. If we don't do that, we'll all be vulnerable. And if there was ever a teachable moment that we're all connected by the environment we share, it's now. And if we don't dramatically change the way we handle preparedness globally, shame on us, because it is absolutely inevitable that there will be another infectious disease emergency that could even be worse than COVID-19. What's not inevitable is that we will continue to be so woefully underprepared as a world.
Thank you so much. Appreciate your thoughts. Let's talk a little bit more about the health systems and the planning and the preparedness, because there were a number of recently published reports that were warning about how COVID-19 could disrupt the continuity of care, as well as continue to deplete health systems and divert resources away from other health issues and campaigns. Let me go to John at Africa CDC on this. John, how are health systems coping on the continent?
My concern is that we, as a continent, we are going to witness a very severe impact on our health systems as a whole. As our pandemic increases, I think that is very clear. I mean, we have. Before COVID-19, we were challenged with endemic diseases like HIV, TB, malaria. We're struggling to beat those, and now that COVID has compounded us. Let me just look at DR Congo for 1 second, where we have an ongoing Ebola outbreak in Mbandaka. And I think it's almost like forgotten, like nobody knows that this outbreak is going there. But if we imagine that if we were in November, last year, and the world heard that there was an outbreak of Ebola in western part of it would be big news. Now we are struggling to make it even bring that to the fore. I think it just shows how COVID has really how resources have all been diverted and applied to COVID-19. We as Africa CDC are really struggling to find the resources to go to Congo to support that. So that's just an example. And of course, HIV, the TB and malaria, our fears is, and serious fear is that this is going to completely undermine that. We should never forget that HIV is still a huge pandemic in our continent, and that we were struggling to win that fight, and the HIV is still there. I think that is very, very important. But very importantly also, I think that we should learn some lessons from HIV as the global community, that what happened in 1996, where HIV therapy was available in 96, and it took so many years for it to be accessible on the continent. That experience still haunts me. I think Peter was the UN AIDS executive director at that time and had multiple initiatives. I remember the Drug Access Initiative in 1998 to try to bring drugs into Africa. I think that same scenario is what I call a nightmare scenario on the continent of Africa, where we are living truly truly hoping that we don't get into a truly very volatile, uncertain, confusing moment on the continent if we do not act in concert. So I think my fear is that the impact will be very severe on the health systems on the continent as a whole.
What is it that you need most right now, John? You know, what is your priority today? I mean, there's the current crisis, there's the fallout of all the other crises that aren't getting the kind of attention and support that they need. But right now, what is it that Africa needs?
So Africa needs at least 4 things that absolutely. That is, one is that we still have a window of opportunity to do a lot on the continent. As I said, more than about close to 40 countries still have less than 5,000 cases there. And that means we need to know our pandemic, as we used to say in HIV/AIDS, know your HIV/AIDS epidemic. So this is the time for Africa to know our pandemic and know it well. So if you take Southern Africa, the whole SADC region, and you unpack that a little bit, you look at the South Africa caseload there with 364,000, but many other countries in that region have relatively low numbers. So this is an opportunity for intervention. And for that, to do that, we need to really increase our testing significantly, back that up with contact tracing, which is supported by strong community workers there. In that we can really, it's not just about a test, but it's the turnaround time. So how do we improve the turnaround time for the test so that the results can actually be effective on? That is very, very important. And lastly, community engagement, such that the core concept of sustaining the ability to wear masks and use it properly is actually maintained. I think those are the things that the continent must do and do it very, very quickly. But lastly, is for the continent to engage in the vaccine dialogue. This is the time for the continent to organize itself, and we've launched the CONVAC, which is a consortium for COVID vaccine clinical trials, so that the continent is playing an active role and a leadership role in that space.
Carissa, what about in Latin America? How do resource-limited countries there balance between COVID-19 and some of these other health areas that John has articulated, as well as, importantly, the impact, for example, on reproductive rights for women and girls?
So indeed, in the Americas, what we've seen is at the first level of care has been impacted. So outpatient services, for instance, we surveyed some 18 countries for NCDs, and we have seen that there has been disruptions of all types of care with NCDs, but more so for diabetes, hypertension, dental care, and rehabilitation services. And this really is greatly concerning when you have an estimated 62 million people in the Americas who are living with diabetes, and 1.2 million in the Latin America and the Caribbean who are living with cancer. And so they are at greater risk of becoming critically ill or dying if they're infected with COVID-19. But we've seen other areas, as you were mentioning, maternal health. That has been impacted. We are seeing disruption in access to antenatal and perinatal care. And this we fear might lead to increased maternal mortality. And we are also seeing immunization programs that have been compromised. You know that Latin America and the Caribbean have the highest coverage for vaccines in the world. And what we are seeing is this impact. We did a study and we see a decrease of some 12 to 14% of our coverage. And that has been impacted by the pandemic, both in terms of international and inter-country transportation and interruption of our immunization campaigns. And I think this is emblematic of what is happening to all of the services at the first level of care. And it doesn't bode well for malaria treatment, continuing of tuberculosis treatment, HIV, etc. All of the chronic conditions that we have to respond to.
Mohamed Pate, given what both Carissa and John are saying, how do you see the role of multilateral organizations like the World Bank in coordinating a robust COVID-19 response and strengthening health systems in the process?
Well, multilateral organizations like the banks provide financing, technical assistance, really to protect frontline health workers so that they can deliver the services, because that's vital. Not only for the primary infectious disease that we're dealing with in terms of coronavirus itself, but also the secondary crisis. the basic equipment that is needed, as well as the testing for that. So through Global Financing Facility, for instance, we're working with 36 countries, the lower income countries, the most vulnerable in this instance, to really help them adapt, provide essential commodities, not only for treatment of basic ailments, but things like reproductive health needs of populations and maternal health services that can easily fall by the wayside. So that's a role that multilateral institutions can play on one hand. On the global good side, I think with the WHO and others, we're involved in the ACT Accelerator to try to see how those tools will be developed, but also when developed, how they will be delivered to ensure that there's global access. It's one thing to have the tools, but the delivery is also important. And so to focus all resources from the World Bank and other multilateral institutions and financing institutions to ensure that when they're delivered, they're delivered with global access in mind.
Do you have any additional thoughts to offer on Africa as a whole from what John was saying from Africa CDC's vantage point?
I think the pandemic has sort of illustrated this. Health is at the center of not only public health, but also economic security and national security. I think investing in health, if we come out of this and becomes a top priority of national governments, heads of states, I think that will be a good outcome. Protecting frontline health workers is also key. I think that's one area that I hope we'll take away from this, because without it, not only are we unable to deal with the pandemic as it's unfolding, but also deal with the secondary consequences. And the Exemplars, I think, also touches on that in addition to national leadership.
Mohammed, Carissa, John, thank you so much. Let's spend the last few minutes that we have now to talk about what comes next with Dr. Swaminathan. Let's first start by looking at, if you can give us an idea based on what you're seeing right now, what should we all expect for the coming months?
Well, I think one optimistic sign we've seen, Zain, despite the exponential growth in numbers, is the fact that mortality rates, or at least case fatality rates, have stabilized. They're not increasing at that same rate. And so a couple of things. One, I think we've learned to manage the disease better. Doctors and nurses around the world have learned from the experience in some countries that have been ahead. And therefore, I think ways of managing people at different stages of the disease, how to monitor them, how to triage them, how to move people into intensive care when they need it, and how best to manage people in intensive care. And also we're learning much more about the pathogenesis and pathophysiology of the disease. So we know, for example, which drugs work best at what stages of the disease. So antivirals, we don't have a very effective antiviral as yet, but would work better in the earlier course of the disease, whereas anti-inflammatory drugs, those drugs that suppress, bring the cytokine storm down, as well as antithrombotics, would be drugs that work in the intensive care. Dexamethasone is a drug that's been shown to reduce mortality. It's a cheap, widely available generic drug, has been shown to reduce mortality, but only in the subset of people who are on respiratory support. So, and this is where I think well-designed, large, robust clinical trials have been extremely important, because what trials like the recovery trial in the UK and the solidarity trial of the WHO are able to do with the large numbers, smaller trials are not able to do. And so I think I would make a plea really for scientists to collaborate in doing well-designed, large randomized trials. So I think that's one thing we can look forward to, is better management. The second thing is diagnostics. When we started in Africa, there were only 2 labs that could do the RT-PCR for this virus. And today, every country on the continent has at least 1 lab, though I wouldn't say that's sufficient. But testing capabilities have increased. And I think what we really need now is a point-of-care test that can be easily used in a doctor's clinic, in a primary healthcare center. And I think there's a lot of effort going into innovation on diagnostics in order to get such a test, which would be a big boon, especially for parts of the world where you do not have these molecular diagnostic labs. And then thirdly, I would say that we've learned a lot about the public health measures that work, and we're still learning. We know very well the precautions to be taken: physical distancing, hand washing, respiratory etiquette, wearing masks, and taking every precaution when staying at home when you're not well, getting tested if you're sick, and generally following the instructions given by the local public health authorities, we know that if everybody complies, that you can reduce transmission to a large extent, because it's been done and it's been demonstrated in countries. And as we learn more and more about transmission, for example, we expand this basket of public health interventions. So till we have vaccine that's widely available and that's been given to enough people to develop that herd immunity to prevent further transmission of the virus, till then, we have to depend on these solid, tried and tested public health measures, and of course, better management, and hopefully we'll have better diagnostics and better treatment options.
Dr. Swaminathan, if I may, on your point about the vaccine, when will we get a vaccine? And we won't hold you to it right now. Well, we might.
So I can make any guess, because anyway I'll be wrong. So I can take a guess. But I would say in the first half of next year. We've just had the results today from the AstraZeneca Oxford adenovirus vaccine. We've also seen results from the phase 2 of the CanSino Chinese vaccine, also an adenoviral vector vaccine, both showing good elicitation of T-cell immune responses and neutralizing antibody. So far, so good. Still lots of questions to be answered. These vaccines actually have to be tested in a phase 3 trial where you can demonstrate actual protection from disease. So efficacy and, very importantly, safety. What's really very encouraging and optimistic is a huge number of vaccine candidates currently in development, 23 of them in clinical development, another 150 or so in preclinical development, wide variety of platforms. And so we can hope that at least a couple of these would hit the target and would prove efficacious and safe. And then we have to manufacture them in large enough numbers at affordable cost in order to reach a significant proportion of the world's population. So we'll probably start off in 2021, first half or middle of 2021, with having some doses available, perhaps a few hundreds of millions, to vaccinate those at highest risk around the world. And this is where equitable access and fair allocation of those very short supply that we're going to have is really important. And this is where the world has to come together, where high-income countries, low-income countries must commit themselves to equitable access. And then as the volumes increase, then more and more people in more and more countries can be vaccinated.
The couple of minutes that we have left, what should be our takeaways from today's conversation from your perspective?
I think what I've heard is, and the lessons that we've learned from the exemplars and from hearing the panelists, is that it's hard work, that this is going to be with us for a while. So whatever we do is not a sprint, but it's more like a marathon. We have to depend on strong public health measures. We have to be driven by the data, and the more granular and the more local the data that we can use. We need to decentralize our responses while at the same time having very clear central policies. And this applies for WHO guidance as well. It needs to be adapted for local context. We need community engagement, in fact, community-led responses. HIV was mentioned several times, and perhaps the success of some countries in Africa is because of the community-led responses that they've been able to foster over the last few years of having really bad HIV responses. We need to make sure that we don't forget about diseases like TB, antenatal care, immunization, because the toll from those could be even worse than the toll that we see from COVID. And that finally, we need to invest in primary health care, in universal health coverage. This is something, of course, that everyone talks about, but I think there's no running away from that anymore. If we need to be prepared for the next pandemic, this is the time really to invest.
Thank you so much for your thoughts. And I'd like to thank all our guests for sharing their thoughts with us here today. And as Dr. Swaminathan said, that this is not a sprint, this is a marathon. This needs to be data-driven. We must decentralize our responses and community responses are absolutely essential. Thank you so much, everyone. Really great to spend some time with you today. I hope you found this event compelling, informative, and inspiring as I have. And thanks again to all our guests for your hard work, your commitment, and for sharing your opinions here today. Just for everybody else watching, I also want to encourage you to visit the Exemplars in Global Health website. That's exemplars.health. So let's continue this conversation on social media through #Exemplars. So make sure you wash your hands a lot, don't touch your face, stay 6 feet apart as much as you can, and most of all, stay safe and look after yourself, and give your loved ones a big hug because you can. Thank you so much. Have a lovely evening. Bye-bye.